Hello, and welcome back to Primary Care Snapshots for the Management of Chronic Kidney Disease, CKD. I'm your host, Dr. Gregory Krol. This is the second in a series of 5 short videos addressing CKD in the primary care setting. Our first video addressed risk factors in working with patients to modify their risk. In this snapshot, we'll discuss key points related to laboratory interpretation and diagnosis of CKD for primary care providers. 2 laboratory tests are essential: the albumin to creatinine ratio, or the ACR, and the estimated glomerular filtration rate, or eGFR. Let's review the ACR. The ACR, which measures albumin excretion in milligrams per day, can be a spot urine test, preferably from the first morning void. However, a first morning specimen is not absolutely necessary or practical. Good news! A 24-hour urine collection is generally not required. An ACR exceeding 30 milligrams per gram is abnormal and indicates albuminuria, a marker for CKD. The urine protein to creatinine ratio, sometimes termed PCR or UPC, is one of the strongest predictors of declining renal function, especially when in the nephrotic range, that is, more than 3.5 grams of proteinuria daily in an average-sized individual. Either test should be performed at least annually for all patients with type 2 diabetes and for all type 1 diabetic patients who have had the diagnosis for 5 years or longer. The second important test for CKD is the eGFR. It is considered the best indicator of kidney function for non-hospitalized and clinically stable patients. Serum creatinine is the primary determinant of the eGFR. There are numerous eGFR calculators on the web. 2 that are easily bookmarked can be found on the National Kidney Foundation's website and the National Kidney Disease Education Program's website. Both adult and pediatric versions are accessible there. What are the key management tips to remember when we're talking about the ACR and the eGFR? First, screen your patients who have diabetes, hypertension, cardiovascular disease, or a family history of kidney disease. Perform both an ACR and the eGFR. Second, if the ACR is greater than 30 milligrams per gram or the eGFR is less than 60 milliliters per minute per 1.73 meters squared on 2 separate tests, 3 or more months apart, the diagnosis of CKD should be made. CKD is not based on the result of an isolated eGFR or ACR, and the diagnosis of CKD requires deliberation regarding causation. Now, as with many laboratory tests, the eGFR does have limitations and inaccurate results may be seen in certain situations. Hospitalization, acute kidney injury, malnutrition, major limb amputation, hepatic cirrhosis, or severe obesity may lead to under or overestimation of the eGFR due to fluctuations of the serum creatinine. Inaccurate results may be seen in the very young and the very old as well. Be mindful of those situations, but understand the eGFR will be a most helpful indicator of kidney status for the majority of your patients. It should guide you in making a confident diagnosis of CKD and its stage. Thank you for watching. Our next snapshot will focus on key details related to potentially helpful and harmful medications in CKD.